A 30-year-old female named S. Rajita, resident of Balaji Nagar, educated up to 5th class, BD worker by occupation, came to the OPD with chief complaints of swelling in the front of neck since 5 years. And she got admitted on 20 July 2026 and examined on 21st July 2026. History of presenting illness. Patient was apparently asymptomatic 5 years back. Then she had noticed a swelling in front of neck which was insidious in onset, gradually progressed from size of pea to currently a size of lemon over 5 years. There is no history suggestive of pressure symptoms. There is no history suggestive of hyperthyroidism. There is no history suggestive of hypothyroid symptoms. There is no history suggestive of metastatic spread. There is no history of other swellings in the neck. Past history, no history of similar complaints in the past. Not a known case of hypertension, diabetes, cardiovascular disease, tuberculosis, epilepsy, COPD, asthma. No history of prolonged irradiation. No history of blood transfusions. There is history of tonsillectomy surgery 5 years back. Drug history, no history of uses of any anti-thyroid drugs or any thyroid related medications. Menstrual history, she attained menarche at the age of 13. Her cycles are regular with 30 days, bleeding 4 to 5 days, and she uses 2 to 3 pads per day. There are no complaints of passage of clots or dysmenorrhea. Obstetric history, she got married at the age of 19 with parity index of P2L2. Family history, no history of similar complaint in the family, or no history of any thyroid related disease in the family. No history of cancers in the family. No history of thyroid swellings in the neighborhood. Personal history, her diet was mixed with good appetite, adequate sleep, regular bowel and bladder movements with no addictions. Summary, a 30-year-old female presented with complaints of progressive swelling in front of her neck since 5 years with no features suggestive of compression of adjacent structures and hypo or hyperthyroidism and metastatic spread. General physical examination. Patient consent was taken and examined in well-latent conditions. Patient is conscious, coherent, cooperative and well-oriented to time-pleasant person. She is moderately built and moderately nourished. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy and edema. Vitals. Temperature was afebrile. Pulse rate was 72 beats per minute measured on right radial artery. Regular in rhythm, normal in volume and character. No radio-radial and no radiofemoral delay. Blood pressure was 120 mm of Hg systolic, 80 mm of Hg diastolic, measured in right arm supine position. Respiratory rate was 16 breaths per minute. Head-to-toe examination. Her hair was black, lustrous. Her face was normal, no facial flushing and no peripheral loss of eyebrows. Her eye signs are negative, like no exophthalmos, no lid retraction or no lid lag, no chemosis and no ophthalmoplegia. Oral cavity was examined and there was no macroglossia or tongue tremors. Skin was normal. Upper limb, no fine tremors were noted. Palms are soft and they are not moist. Lower limbs normal, no pretibial mixed edema. Local examination of neck. Inspection. Patient was examined in sitting position with neck extended. A solitary swelling was present in anterior side of neck, which was oval in shape, measuring 16 to 5 centimeters approximately, extending from superiorly below the thyroid cartilage, inferiorly above the sternal notch, horizontally from midline to anterior border of sternocleidomastoid. Surface is smooth with well-defined margins. There are no sinuses, scars, engorged veins, or visible peristalsis. Swelling moves with deglutition and doesn't move on protrusion of tongue. Trachea appears to be in midline. Palpation. There is no local rise of temperature and tenderness. There is solitary swelling in left anterior side of neck, which was oval in shape, measuring 16 to 5 centimeters, extending from superiorly below the thyroid cartilage, inferiorly 2 centimeters above the suprasternal notch, horizontally from midline to anterior border of sternocleidomastoid. Surface is smooth with feminine consistency. Lower border of the swelling is palpable. Skin over the swelling is pinchable and mobile in horizontal and vertical directions. Lahey's method was done and lateral borders are palpable and each lobe is palpated. Kreil's method was done and no nodules are noted, multiple nodules. Koch's test was done and it was found to be negative. Trachea is in midline. Carotid artery is palpable bilaterally at anterior border of sternocleidomastoid at the level of thyroid cartilage. Cervical lymph nodes are not palpable. Percussion. Resonant note was heard on direct percussion over manubrium sterni. Auscultation. No breath was audible at upper pole of swelling. Systemic examination. CVS S1 S2 head, no murmurs. CNS, no focal neurological deficits. Respiratory system, bilateral air entry was present. Vascular type of breath sounds with no adventitious sounds. Abdomen, soft, non-tender, no organomegaly. Summary of the case. She is a case of 30-year-old female presented with complaints of progressive swelling in front of neck since 5 years with no features suggestive of compression of adjacent structures or hypo or hyperthyroidism and metastatic spread. On examination in inspection, a solitary swelling was present in left anterior side of neck which was oval in shape, measuring 6 into 5 cm, extending from thyroid cartilage above to suprasternal notch below, and horizontally from anterior border of sternocleidomastoid in the to midline. The surface is smooth with well-defined margins and swelling moves with deglutition. On palpation, all inspectory findings are confirmed and skin over the swelling is pinchable and mobile in vertical and horizontal directions. The lower lobe is palpable. The Lahis and Kryle's method were done to confirm no multiple nodules. Carotid artery was palpable bilaterally. Provisional diagnosis. This is a case of left-sided swelling of thyroid gland, most probably solitary thyroid nodule with functional euthyroid state with no evidence of pressure symptoms or signs of hyper or hypo or malignant change. So the patient was examined in sitting position with neck extended. There was a solitary swelling present in the left side of neck which was oval in shape, measuring 6 into 5 centimeters, extending from superiorly below the level of thyroid cartilage, inferiorly above the sternal notch, horizontally from anterior border of sternocleidomastoid to midline. The swelling is smooth with well-defined margins. There are no scar sinuses and engorged veins and visible pulsation. You can appreciate the swelling moves with deglutition and doesn't move. And it doesn't move with protrusion of tongue. Antu unnadu ఒకసారి. There is no cyanosis when the Pemberton change was performed. This was the Provisional method. It is performed in short stature patients and obesity patients to visualize the swelling perfectly. Patient was examined in sitting position. There was no local rise of temperature and no tenderness. Here we can see a solitary swelling in lateral side of neck, lateral to the lateral to midline. Now we will measure the size of the swelling. ఒకసారి మింగండి ఒకసారి మళ్ళీ ఒకసారి మింగండి. ఇప్పుడు ఒకసారి. It's approximately 5 to 4 centimeters. The best method of examination is to stand behind the patient and the 4 fingers should be in front of the neck, in front of the swelling, and the thumb should be at the occipital level. Now he is feeling for the consistency. The consistency is smooth. The consistency is feminine consistency. The surface is smooth. Lower border swelling. Look for the lower border. The lower border of the swelling is palpable. Skin over the swelling, pinchable or not. So skin over the swelling is pinchable. Mobility. And he is looking for the mobility in all directions, in horizontal and vertical. So it is mobile in horizontal and vertical positions. Now we will perform Lahis method. From Lahis method, we will push the swelling from one side and we will feel for the other lobe. He is pushing from the left side, he is feeling for the right lobe with the left hand. Now he is pushing from the left hand and he is feeling for the lobe in the right hand. Nodules are felt in Lahis method. Next, Kyle's method. So non-auditory is present. He is obstructing the lateral. He is obstructing the trachea by pressuring from both sides, which creates pain in the trachea and leads to stutter. There is no stutter in this patient, so it confirms.
అమ్మ నోరు తీసుకొని ఊపిరి తీసుకొని నోరుతో గట్టిగా.
So there is no stutter in the patient. Confirms there is no multinodular goiter. Was carotid pulse was examined against transverse process of 6 cervical vertebra between posterior border of thyroid and sternocleidomastoid. So here I can feel the carotid pulse. So I can feel the carotid pulse on both sides. Resonant note was heard on percussion of Manabrain Chennai with direct percussion. On auscultation, we will look for the bruit over the upper pole of the swelling. There is no bruit heard over the upper pole of the. Let's discuss about the case now. Here the patient is a 30-year-old female. Female indicates because thyroid is more common in females, and the swelling gradually progressed over years, which indicates it is not malignant mostly, and there are periodic symptoms, which means the thyroid compresses. If thyroid compresses esophagus, which leads to difficulty in swallowing, and difficulty in breathing is due to thyroid can compress trachea, and also in thyrotoxicosis it leads to congestive cardiac failure, which leads to difficulty in breathing. Change in voice because thyroid could compress the recurrent laryngeal now. And we asked about hyperthyroid symptoms because a toxic nodule could present with solitary nodule with hyperthyroid symptoms. For few examiners we should tell like no issue of hyperthyroid symptoms like increased appetite and diarrhea, and we should detail everything. And we asked about hypothyroid symptoms because Hashimoto's thyroiditis could present with a solitary nodule with hypothyroid symptoms. We asked about metastatic spread because it could spread metastatically, led to brain, lungs, liver, bone. In brain it leads to headache and seizures. In lung it leads to cough, hemoptysis. In liver, jaundice, bone pains. No issue of other swellings because cervical lymphadenopathy could indicate malignancy, and brachial torulode brachial cyst and thyroglossal cysts. In past history we asked about similar complaints in the past to rule out any recurrence. We asked about hypertension because hyperthyroidism can worsen the hypertension. Diabetes because diabetes could increase the risk of post-op operative. Asthma because beta blockers are used in hyperthyroid symptoms like Provisional. It may worsen asthma. Cardiovascular disease because hyperthyroidism could present as tachycardia, atrial fibrillation and heart failure. Tuberculosis is rare, and epilepsy is important for anesthetic drug and perioperative medications. And we asked about menstrual history because hyperthyroidism could present as oligomenorrhea or amenorrhea. Hypothyroidism could present as menorrhagia. And we asked about obstetric history because recurrent abortions are more common in hypothyroid patients because in early pregnancy fetus mainly depends on maternal thyroxine, so maternal hypothyroidism could lead to pregnancy loss. And we asked about personal history. In personal history, the diet is important because iodine deficiency could lead to goiter. Appetite, increased appetite with weight loss is seen in hyperthyroidism. Decreased appetite with weight gain is seen in hypothyroidism. Sleep, insomnia is seen in hyperthyroidism. Excessive sleep is seen in hypothyroidism. Bowel and bladder movements, diarrhea is seen in hyperthyroidism. Constipation is seen in hypothyroidism. Smoking is important for Graves' ophthalmopathy. In general physical examination, we asked about the conscious, coherent, cooperative because in mixed edema coma the patients could lead to coma, so patient doesn't have consciousness. It is seen in hypothyroidism. In hyperthyroidism also it could present as coma. And we asked about in edema because non-pitting type of mixed edema is seen in hypothyroidism. And in head to toe examination, hair dry and brittle hair indicates hypothyroidism, fine and hair loss indicates hyperthyroidism. Facial flushing is seen in hyperthyroidism due to increased peripheral vasodilation, and peripheral loss of eyebrows is also seen. Oral cavity, macroglossia could be seen in hypothyroidism due to mucopolysaccharide deposition. Trunk tremors are seen in hyperthyroidism due to increased adrenergic activity. In skin, hypothyroidism, it could lead to dry and cold skin. Hyperthyroidism, warm, moist and sweaty skin. Upper limbs, tremors are seen because of beta adrenergic activity, which stimulated by increased thyroid. Lower limbs, pretabial mixed edema is important because it is a non-pitting type of skin edema due to autoimmune glycosaminoglycans deposition. It is indicates important in Graves' disease. In vital, pulse is important because in hyperthyroidism there is tachycardia with irregular rhythm and high volume pulse. With collapsing pulse also could be seen. In hypothyroidism, bradycardia with low volume pulse and is mainly seen. And blood pressure is important because in hyperthyroidism it could lead to white pulse pressure, which means increase in systolic and decrease in diastolic. In hypothyroidism, hypertension with narrow pulse pressure is seen. What are the differential diagnoses for this case? It could be colloid goiter, it could be a benign follicular adenoma, it could be dominant nodule of multinodular goiter, which we missed during the palpation, and it could also be thyroid cyst, it could also be a malignant transformation. But in this case, malignant transformation and thyroid cysts are rare. Why? Because thyroid cyst usually enlarge suddenly, and malignant transformation is not there because there is no fixity and carotid pulse is palpable and trachea is not deviated. So the main differential diagnosis could be colloid goiter, benign follicular adenoma, dominant nodule of multinodular goiter. What are the investigations done? The investigations done in this case are radiologically USG-NEC is done, cytologically FNAC is done, functionally T3, T4, TSH levels are done. So management depends on based on the investigations. If it is found to be colloid goiter, if it is small, then no surgery is needed, and if it is benign with symptoms, hemithyroidectomy is done. If it is malignant, we need to do total thyroidectomy. And if it is found to be benign follicular adenoma, then hemithyroidectomy is performed. If it is found to be dominant nodule of multinodular goiter, if it is benign, we should mainly observe the case. If it is large or cosmetically concerned, or it is malignant transformation, then surgery is indicated. In thyroid cyst, aspiration is done. If it is found to be malignant, then in papillary or follicular or medullary carcinoma, we need to do total thyroidectomy.